Good afternoon, everybody. Welcome to SEVA VentRounds. Today is June 24th, 2025. And the topic of today is safety, tolerating effort. There is no endorsement of any mode, ventilator, or manufacturer. Whatever we say, it's our opinion. It does not represent the Cleveland Clinic. And those are our disclosures for Rob and myself. The ground rules is keep your microphone muted. However, if you have something to share or ask or comment, just please unmute yourself, or you can put it on the chat function. Both of them are being monitored as we speak. At the end of the lecture, there's CME for the CCF providers, and there's CRC credits for all the respiratory therapists. Remember, you have to fill your evaluation form. So this one, we're gonna just skip directly to the meet. It's mid-June, sorry. And the goal is to start reading this waveform from the get-go. And I put every single part of the data that we have on this patient. This is an active patient that we have currently. And so I'll start just by highlighting that the goal for this patient is safety. And so I'll put it up here just for everybody to be aware. This is a patient with severe hypoxic respiratory failure post a brief cardiac arrest with multiple other issues going on. But I hope that that gives you just an idea of where we are in the care with this patient. So the first thing is, what is the tag? And as usual, type it in on the chat. Yeah, and this is at this level, we are already on board with the tag. So rapidly, thank you, Karsten, Fair, and Annika, all on the point. So this is pressure control, CMVA, and there's some features on this image that can guide you that this is pressure control. And so the first one is, if you just look at the flow waveform, it doesn't look anything geometric. And the pressure waveform tries to be a square, recognizing that the ventilators cannot deliver a beautiful square waveform when there's Pmus there. But because they cannot control pressure as well as they can control flow. But that's one of the markers. The tidal volume is pretty identical between the two of them, but there's a little bit of variation. So it's definitely pressure control. Rob?
It covers everything.
All right. In terms of CMV, so that means that all breaths are mandatory. And just looking at these breaths that you have active right here, immediately, this is a servo ventilator. And when a breath is triggered by the ventilator, it changes color, either on the pressure or the flow waveform. And in this case, it would turn white on each one of those waveforms. And we don't see that happening, right? There's no change. There's also no deflection before the pressure waveform, which it's not always there. And we also don't see an increase on the flow above the baseline. So these are mandatory breaths.
You said triggered by the ventilator. You meant triggered by the patient.
Yes, these are not triggered by the patient. These are triggered by the ventilator. So these are mandatory breaths. You don't have any of those markers. So just by being triggered by the ventilator, immediately they become mandatory breaths. There's other items that can tell you that this is a mandatory breath, and there's some features that we will talk later that tell you that there is inspiratory time, and you can see some features of that. But right now, suffice to say that this is triggered by the ventilator, and so immediately those two breaths that you see right now are mandatory. And then it says adaptive, and frankly, just by looking at this waveform, it would be impossible for us to say this is adaptive or not by looking at the waveforms. But by looking at the screen, there are some key features here. The first one, there is a tidal volume that has been set. And two is I didn't play any tricks, and I put here the commercial name, which is PRVC. And for anybody that has a Rosetta card or uses the VentMode app, they will immediately know that this is a pc-cmva or adaptive. And that means that the ventilator is trying to target the set tidal volume, which in this case is 370. Rob, comments?
Yeah. Some people say, and I'm not sure what Ariel's comment was there, that if you set a tidal volume, then that means volume control, but it does not. By definition, volume control, by the equation of motion, you must set both the flow and the tidal volume. So
Right.
if you just set one of those two, it always ends up being a form of pressure control. And there are modes where you set one or the other, but if you set both, then it becomes volume control.
Excellent. Great points, Rob. And that has to do, these are nuances that are required in a taxonomy to ensure that we're classifying all the modes correctly. And there's some modes that took us off guard and that can help you when you follow the rules appropriately. Well set rules can help you do this very clearly. I think that Rob, what Ariel is putting there is that the same mode, the same name of the mode in another ventilator, it's a different tag. And that's something that we recognize actively on several. I mean, there's modes that are called volume control that have different tags, even though it has the same commercial name. So thank you, Ariel, for highlighting that. Alrighty, so we are on pc-cmva. So what's the load during inspiration and during exhalation? The A11 fellows unanimously hit it right. Really good. So during inspiration, there's no question that PMOS is present. Even though it's a patient ventilator, a machine-triggered breath, so it's triggered by the machine, you don't see the exponential decay that you would expect to see on these patients. So if I just trace it, it should look like that. And, I'm going to put a little bit more color so you can see it a little bit better there. That's what we would expect if it was a passive breath. And instead of that, we see all this activity from the muscle occurring throughout. So there's definitely PMOS. And then during exhalation, what we would expect to see is something that would come down and would go like that. And instead of that, we see all these undulations that are occurring over here that I'm highlighting with all this stuff, which is activity of the expiratory muscle. So this patient is actively exhaling. Non-regardless, perhaps there's some passivity at the beginning, but whenever there's PMOS, you cannot fully read the waveform. And so I cannot see how fast. And so you could say, well, is there obstruction? But this is maybe just the activity of the PMOS. Rob, comments?
Yeah, quick comment. You notice that this ventilator is displaying a dynamic compliance value of like 84.
Yes.
And it has that little asterisk, and that should warn you that that's probably not a valid number. Normal patients have a compliance of on a ventilator something like 50 or 60. Patients with ARDS less than 40, clear down to 10. And so you can't believe that number. Just be aware of that. And you can't believe it because of the PMOS.
Well, this is going to become so evident in a couple of seconds. So I'm so glad that you highlighted that, Rob. This will come as we go through this and the concept of safety. So I think that your observation, we will certainly come back to it after the discordance. But just keep in mind this very key concept that Rob has brought up. Excellent. Alrighty, I'm gonna erase for a second the normal waveforms that we would be expecting to see, and we agree that there is a lot of PMOS activity here. So the first question, in terms of PV discordance, my friends, is what PV discordance we see in terms of trigger? Yeah, Lorenzo, excellent. So this is. This would be something that people would not have recognized. But once that you start saying, okay, who triggered the breath? Because if I had walked by and seen this waveform without knowing who triggered the breath, I would have said this is a perfectly synchronous breath. you know, I, I would. I mean, you're just saying it's hard. It was hard to me to see it, but you're absolutely right. This is what we call an early trigger, and in this case, the variety that the patient has is what is known as reverse trigger. This patient had received some sedation at that time. Oh my God, what am I writing? Trigger. And what you see is, even though it's machine triggered, immediately afterward, very soon thereafter, the presence of Pmus becomes evident, and it's throughout the breath. So this is an early trigger. And yes, Karsten, this is very subtle, and you would only have recognized it just by going methodically, saying who triggered the breath. If not, you would have missed it. And actually, I can tell you that when I took this picture, I missed it. It was until I put it on the slide that I said, "Ha, Eduardo, you have been fooled once again by lack of good eyesight." Alrighty. So now that you have seen the early trigger, you immediately know that the rest of the abnormalities that you're going to see are a manifestation of the early trigger. But suffice to say that if we wanted to grade inspiration, is this assistance, under assistance, or over assistance? Yeah, this is very interesting. I love this. And this is a tricky question because you're looking, and the pressure is above the baseline, right? So the pressure above the baseline means that the ventilator is delivering support to the patient. The patient is generating effort, but the ventilator is generating some amount. So there is definitely work shifting. There is no question about that, right? There is work that is being done by the ventilator and work that is being done by the patient. And remember that in adaptive mode, there is a inverse relationship between them. The more PMOS, the less P-vent gets delivered. We agree with that, right? And so as you think about that, there is some amount of assistance that is occurring. And the question is this under assistance? We know this is not over assistance. Is this under assistance? So if we come and take a look at the tidal volume, is the tidal volume a target? And it's pretty close. I mean, the target is 370. The patient is getting 1 cc per kilo more than expected, and the pressure is above the baseline. It's above the baseline. So I would say that at least the patient is getting some amount of work being done by the ventilator in there. So how could we assess under assistance in this circumstance? Yeah, yeah. So it start coming in. So now your brain, you see how the evolution of this has gone. Is that in the past we were only looking at the tidal volume as our target, and you would say this is safe mechanical ventilation. The patient is getting a peak pressure of 20 on pressure control with a tidal volume of 7 cc's per kilo, which is still within what the ARDS net guidelines, the trial we would consider to be safe. I mean, I know that we tried to get to 6 dogmatically, but you could say that's still within what the studies have done. So, over the last recent years, we have been starting to look at the Pocc. So let's bring out the Pocc. Are you ready? For the viewing pleasure of the team, here it is. And so I have added here the Poccs. And so this was done by Simran, one of our fellows, who always does 2 pulses on all our patients, one inspiratory and one expiratory. And she did the expiratory pause on this patient. You can see the waveform back here, which is identical to the other one. And the baseline pressure was 12. So this patient was on a PEEP of 12. And I can show you that. You can see the PEEP of 12 over here. And at that period of time when they did the Pocc, it was 12. Now, we can argue if that should be the pressure that we use to measure the Pocc, but that's what they used on the trial per se. And then you can see that the pressure during the effort goes beyond, disappears from the scale, and that's something that will always happen. And some ventilators do not measure, but this one does. And so you have to move the cursor until you find it. So this patient went from 12 to minus 13. So the Pocc on this patient is, well, 25. Yeah. Rob, comments here.
Strictly speaking, it's minus 25.
Thank you very much. Talk to us a little bit about that. What's the error that frequently occurs in the literature?
And I wrote a paper about this, which will come out shortly. It'll appear as a letter to the editor in Respiratory Care Journal, but it analyzes the historic development of inaccuracies in the equations and how people write the numbers and even the terminology. So I don't have time to get into all that, but basically, mathematically, what you're doing is you're taking the lowest pressure, which you can't see graphically, but you see it's minus 13, right? And then you subtract, so that's the end pressure, and then you subtract the start pressure. Why? Because it's delta P over delta T. So what's delta T? Well, it's T2 minus T1. So the pressure has to be pressure at T2 minus pressure at T1. So that's minus 25 minus 12, which is minus 13 minus 12, which is minus 25. So there you go. And you can see the amplitude, the absolute value of the amplitude is 25, and you would interpret it the same way as a minus 25, but mathematically to be accurate, and so we're all on the same page, it's a negative number.
Excellent. Thank you, Rob,
Sure.
for that clarification. Yeah. Anything else? I thought that you were going to say something else.
Well, no, the same logic carries over to PO1, but we're not going to get into that.
No, and in this case, PO1 was 3.5 for this patient, and we measured it accurately. But so this patient is generating 25 of Pocc. Now there's two values that we can use from the Pocc, right? So one is to estimate the Pmus. So the Pmus would be is you use this this value, and you multiply it. In the Bertoni article, they used a constant of minus 0.75. And so if we multiply 25 times 0.75, that gives us thank you. So 19. So that's a Pmus, and again, all these thresholds are in evolution, but it seems that the threshold for a very high Pmus in which injury to the diaphragm and PCL can occur is around 15. So that's one of the numbers. The other number that you will see estimated is the estimated esophageal pressure. And so you can estimate, remember these are estimations for the esophageal pressure. And for that one, they use 0.67, so 67%. And these are adjustment factors that they use to validate the measurements against an esophageal catheter. And so if you multiply it by 0.67, that would give you come on, fellows. Yeah, thank you. So we'll round it at 17 just for the sake of it. So there's a difference between the Pmus, because the Pmus includes the chest wall and the esophageal pressure, which doesn't. And so you have this esophageal pressure, and this is relevant because in that paper, they went to the extent of calculating a thing that they call the transpulmonary, and that's the sign that they use there, transpulmonary dynamic pressure. which is a marker of the risk in the dependent areas for patients that are spontaneously breathing. And so those areas may see higher values. So there's some issues with this formula in general because it's the airway peak pressure. And you could argue that the airway peak pressure is not necessarily this one, but it would be the pressure over here. So it depends where you measure it. But in this case, the peak airway pressure was 20, the PEEP was 12, and then the 67, this is 17. So if you do that value, what's the result that you get? Come on, my mathematics experts. No, not 3.39. So 20 minus 12 is 8. 8 minus 17 is 9. And so that's well below the threshold for injury to the lung. Now, I'm putting this right here because this is relevant for us. All these values are starting to go into the literature, and how much of that do we have evidence for as protective strategies for the lung and the risk of PCLE and the risk of injury to the lung. So I'll ask this again. Now you have all these values. You have a very high Pocc, a very high effort that you can see with the estimated Pmus. And you have this curve. And the question is, obviously, this patient, we're trying to fix the early trigger by decreasing the rate and whatnot. Rob, can you again explain the Pmus was minus 25?
What was the Pocc?
So the Pocc is minus 13.
Minus 13. And then you multiply by minus 0.75.
Yeah, but that's later. So let me walk you back from the beginning. So Karsten, we measured the airway pressure and it was 12, right? And so the delta in pressure, it went all the way to the nadir of to minus 13. So the change the pressure dropped 25 from baseline total. So it went from a PEEP of 12 all the way to minus 13. That's where the 25 comes through. And that's a negative number, correct, Rob?
Correct.
Okay. Does that help, Karsten? Got it. Excellent. So now you have that 25, and then to get to the Pmus of 19 is because we multiply it by a factor of 0.75.
Minus 0.75.
Thank you. Minus 0.75. And the esophageal pressure calculated is minus 0.67. Those are the factors that you multiply that value, and it gives you these estimates. So now you have those values there, and you come and see this patient, and you have to make an assessment about safety. And this is where this CDIN becomes very relevant for me, because what you're talking about, Rob, you come to the bedside and you see the patient and you say, well, the patient is getting 7 cc's per kilo, which falls within our safety threshold. You may say, oh, look at the compliance. It's wonderful. But this is a compliance that it's including 25 centimeters of water pressure of drop, in which the patient is doing a lot of Pmus, and it's dropping the airway pressure by 25, plus the 8 cc's or 9 cc's that the patient is getting of driving pressure over here to inflate that lung. So it's around 32 centimeters of water pressure difference that the patient is generating. So if you calculated the compliance then using 32 centimeters of water, this patient is generating there's a tremendous amount of pressure that is going through there. And so this is, I'm not going to make a determination right now because I don't think that we have the full amount of evidence out there, but this is a very high amount of effort being generated by the patient with very injured lungs. And so I would say that if your goal is safety, This patient probably need, I mean, if the goal is safety, you probably want to decrease somewhat the amount of respiratory effort that the patient is generating at this time, just because of the magnitude is so elevated. And there's obviously early trigger, but it's not a terrible amount of early trigger that I would say that that's not my major issue. My major issue is the amount of PMOS that it's there. Go ahead, Rob.
I just wanted to point out that this Bertoni paper is very good. I recommend that you read it.
Mm-hmm.
And to point out that they used a coefficient of negative 0.75 to estimate Pmus. Why did they do that? Well, because Pmus is always positive. And if you have a negative Pocc, then you got to multiply by a negative coefficient to get a positive estimate for Pmus. Now, that said, I question that number of 0.75. And in my editorial, I showed another paper that indicates that it might be above 1. And it doesn't make sense to me why Pmus would be less than Pocc. How could that be?
Yeah.
These are questions open for more research. We don't have the answers for these things, but
Absolutely. I think this is a key item for us to come to terms on how to assess this. But this is the what we're using right now for trials and what we're using for measurements. So it's just relevant for all of us to start thinking and get used to this. But I would again say that what Simran does every day, which is when he approach the ventilator, you do an end inspiratory and an end expiratory pause. It's a key feature to recognize not only the presence of under assistance, but also the presence of false trigger, which is a huge issue. So this is wonderful thoughts. And yes, thank you, Ariel, for your comment regarding why the PMOS is lower, because this is trying to equate to what the patient would be getting when they're getting some support. So thank you. So with that, I think that we are at the top of the half an hour, but the key findings is the first one is do recognize to go in order. I mean, we see a case of early trigger that it's very subtle, but it becomes evident once that you go in order and you recognize that the pattern is a machine triggered breath followed by patient activity. And recognize that early trigger, the reverse trigger is one of the many causes. This is not the only cause of early trigger. The second one is that the dynamic, what the ventilators call dynamic compliance, can look normal or beautiful. It can look great, right? You will see it and you would be excited about what you're seeing. In this case, 89. That's actually supranormal it's a high number for somebody on mechanical ventilation. But that number is including the PMOS. And so it's PMOS plus the P-vent, and that's giving you that number that you see there. And so the number itself is meaningless in terms of the actual compliance of the lung. And then the third one is that we talked about how to estimate PMOS esophageal pressure according to the Bertoni paper, which is very good. We talked a lot about the symbols, the negative and positive, and this is a common source of error in the literature, and you have to be aware of it. But for the bedside, it's important for us that because it helps us recognize increased respiratory effort, which in the appropriate setting, like in this case, a patient with safety is the main goal, may be causing injury on some areas of the lung. And so the take-home message overall is that follow what the key items is. If you don't do an end inspiratory and an end expiratory hold in every patient, every time that you're assessing the interactions, if you don't do these two, you're going to miss half of the picture. And then you have to put this into context. I would say that there's a question there. What did we end up doing with this patient? So at that point, in our discussion said, this is a very high PMOS. There's a very high respiratory drive, and you could see the activation of the inspiratory and expiratory muscles, even though the patient was sedated. I mean, it's in flux of sedation. So we increased the amount of sedation to get her into a more acceptable PMOS at that time, given that we had increased the pressure, increased the PEEP, and that continued to have high respiratory drive. She was already on 100%. And so the only alternative was to do a little bit more sedation. And that's where we ended with that patient. There's going to be another assessment, and then based on that assessment, we'll decide what else to do. Yeah, so I hope that this was useful for all of you. Rob, any final words of wisdom while I put the CME for CCF caregivers?
No, just to point out that Karsten made the comment that he said he supposes that the interpretation would change how you treat the patient, and he noted that he saw an early cycle as well. And yeah, that happened, but it was because of the early trigger. And you don't treat the early cycle, you treat the early trigger.
Exactly. That's perfect. Again, for all of you that want to go to the SEVA Summit, please register. We have very few slots open, so you really need, if you want to go, register yourself. There's other opportunities coming, but we look forward to having you there, and really, really great insight from everybody. As usual, we are learning, and I'm sure that 10 years from now or 2 years from now, we're going to see this and say, oops, we were so wrong, but we tried to be as good as we can. Thank you all. In 2 weeks, we're going to have a great case that Ariel has sent to us of non-invasive and some settings that we need to understand better how to use and why we would use them. Thank you very much. Have a great day. Bye-bye.